I'm Naomi Laventhal. I'm one of the faculty ethicists in the program for clinical ethics within the Center for Bioethics and Social Sciences and Medicine. It's my great pleasure today to introduce to you my mentee, Christy Lawrence. Christy got her undergraduate degree in physiology from Michigan State, with a specialization in bioethics. She then stayed at Michigan State to get her degree in osteopathic medicine there, was a pediatric resident and a chief resident at St. John Hospital in Detroit. And then we were fortunate enough to match her here for neonatology fellowship in 2017. Christy's been committed to bioethics since her start here. She eagerly joined the Pediatric Ethics Committee almost as soon as she started. She's on the Michigan State Medical Society Ethics Committee as well. And she's been doing a lot of interesting work in both prenatal consultation and perinatal birth asphyxia in her time here, resulting in a number of presentations at national meetings and some manuscripts that are accepted and in press. And she's got a great talk for you prepared today that I think does a really nice job of blending her love of clinical medicine with her emergence as a bioethicist. And with that, I'll give it over to her to give you a great talk.
Thank you for the introduction, Dr. Laventhal. Thank you all for being here and for giving me the opportunity to speak with you today. Today, we will dive into an ethical analysis related to perinatal birth asphyxia. I do not have any conflicts of interest. I would like to take a moment to say thank you to my faculty mentors, Dr. Laventhal and Dr. Kokora. I would also like to thank the Division of Neonatal Perinatal Medicine and the Center for Bioethics and Social Sciences for giving me the opportunity to present today. Today, I will provide you with a contemporary and clinically informed ethical analysis of decision-making for newborns affected by significant perinatal hypoxic ischemic encephalopathy. We will explore ethical issues related to specific clinical scenarios and contexts related to postnatal care of infants with HIE. I will discuss recommendations on how to improve decision-making for infants, and we will navigate through past, present, and future ethical issues in this field. I will build today's presentation around a case of which I will call the baby Sarah. Sarah is a one-day-old infant girl born at a community hospital, delivered by emergency C-section in the setting of placental abruption, or lay terms, obstetric hemorrhage. Sarah was lifeless at birth, without spontaneous breathing or a heart rate. She was aggressively resuscitated, and spontaneous circulation was established at 20 minutes of life. As her labs began to come back, it became clear that Sarah's organs had been deprived from oxygen for a period of time before birth. She was extremely ill. Sarah was transferred to a regional high-level NICU capable of caring for someone so sick, particularly able to provide targeted treatment for asphyxia-related brain injury. As it became apparent that Sarah's brain was severely injured, her parents arrived from the delivery hospital. They seemed exhausted and disheveled. The team explained that Sarah might die, and that survival would likely be accompanied by permanent brain injury. Two big questions were proposed for thought. Should we change Sarah's code status to DNAR, and how do we decide whether and when to redirect care? The parents were in shock seeing their baby so sick, and they said that they needed time to think about all of this. Birth asphyxia is something that most people have heard about, especially from a lawsuit standpoint. Googling birth asphyxia leads to a long list of lawyers offering to help in such cases. This is one of the many reasons why C-sections are common and OB malpractice is so high. Despite hearing about it, no one would expect it till it happened to them. Birth asphyxia leads to hypoxic ischemic encephalopathy, referred to as HIE, which occurs following a catastrophic obstetric event around the time of delivery, leading to diminished blood flow and impaired oxygen delivery to the brain and other fetal organs. Infants with HIE often require numerous medications and high technology interventions to survive the immediate perinatal period. While even severe injury to other organs is often reversible, brain injury is not, and HIE can result in permanent neurological impairment. The overall incidence of HIE is about 3 to 5 per 1,000 live births in term infants in developed countries, and as high as 26 per 1,000 live births in developing nations. Prior to initiation of targeted therapy, studies have shown between 10 to 60% of infants die worldwide, and approximately a quarter of survivals having long-term disability. The prognosis for HIE is variable, depending on severity. In mild cases, there is typically a good outcome with no neurological deficits. Moderate encephalopathy is the least predictable, with some infants going to complete or near complete recovery and others with more permanent effects. Severe cases often lead to significant impairment or even death. Neonatal resuscitation procedures are highly scripted and choreographed, and resuscitative efforts are quickly escalated based on the baby's needs in the delivery room. There is no time in these initial moments for subtle risk stratification. Staging of HIE typically occurs after initial stabilization of the infant. We use strict criteria for staging infants with HIE. These criteria date back to 1976, which shows that this has been a long-standing problem with only a fairly recent history of being able to provide specific targeted treatment, of which I will discuss. When thinking about severe encephalopathy, I think these criteria paint a picture of how sick these babies are, often appearing lifeless without movement, and some of them taking no breaths on their own. While mild HIE generally does not warrant targeted treatment, therapeutic hypothermia, referred to as cooling, has heralded a paradigm shift for children with moderate to severe HIE. Strong empirical evidence demonstrates a decrease in mortality and a decrease in both frequency and severity of neurologic sequelae, such as developmental delay, seizures, and cerebral palsy, among infants with moderate and severe HIE, although these benefits are largely accrued in the moderate HIE group. Therapeutic hypothermia is a fairly newer therapy, with trials published between 12 to 15 years ago. It is now the standard of care for neonates diagnosed with moderate and severe HIE. Cooling must be initiated within 6 hours of birth and requires a highly specialized bundle of care at a high-level NICU with frequent lab checks, strict fluid management, and continuous monitoring of vital signs. Additionally, babies are not able to be held or to be fed during the 3-day period that they are being cooled. Brain imaging and nuanced prognostication usually follows completion of the 3 days of cooling. There is a Cochrane review that reviewed 11 randomized controlled trials with over 1,500 infants with moderate to severe HIE who underwent therapeutic hypothermia. They showed that therapeutic hypothermia resulted in a statistically significant and clinically important reduction in both death and moderate to severe disability. The number needed to treat to provide reduction in both mortality and major neurodevelopmental disability by 18 months is 7. When we think about number needed to treat in neonatology trials, this is an impressive treatment therapy. Now let's go back to our case. We talked about how Sarah was so sick and that therapeutic hypothermia had been initiated, but that the team was very worried about her. It was clear that without intensive care, Sarah would not survive. While providing this care, the medical team worked hard to stabilize Sarah and to elicit parental values. Sarah's parents and grandparents were counseled that she was not likely to survive the early hospitalization. Despite seemingly non-survivable multi-system organ failure, Sarah stabilized and survived to rewarming and further evaluation. Even with improved physiologic stability, Sarah's family was warned that her extensive brain injury, substantiated by a profoundly abnormal MRI, would prevent her from breathing on her own off of the ventilator. Her parents seemed ready to discuss redirection to comfort care. Sarah's parents were also counseled that she might not ever be able to feed by mouth, but she began bottle feeding, again without much difficulty. Sarah's parents then started asking the team more questions about how she would be affected by her brain injury. By this point, the team had come to know the parents better, and they started asking tough questions about Sarah's future. On learning that the full effects of Sarah's injury would take months to years to become apparent, Sarah's father at one point remarked, "So this is basically a crappy waiting game." Behind closed doors, Sarah's medical team would also discuss whether the decision to continue with therapy in the first few days had been the right one. Ultimately, Sarah was discharged home with her family at 3 weeks of age, on no medications, taking all of her feedings by bottle. Follow-up at 2 years of life showed that she was not meeting any milestones, had severe developmental delay, and was unable to communicate with her family. Decisions regarding pursuit of aggressive therapy versus redirection of care are complex, high-stake decisions under great uncertainty. At first, a medical team is often focused on the basic measures to keep the baby alive. Meanwhile, the family of the neonate are often stressed and confused as they were anticipating a healthy full-term baby. There is no previously established physician-patient relationship, so it may not be easy to elicit parental values in such an acute situation of shock. While working through all of these things, if the baby survives through those first few sick days and becomes stable, they have a good chance that they'll make it home. However, in severe cases such as Sarah's, the neurological outcomes are often very poor. Prognostic uncertainty makes us uncomfortable. When we talk about prognosis using population data, it doesn't pinpoint what will happen to the individual patient. For example, just because there's a survival probability of 30%, that does not mean the individual baby has a 30% chance of dying. The individual patient will either live or will die. Uncertainty can provide a lack of reliability and credibility when providing consultation to a family. Additionally, it might lead to variability in practice patterns between physicians. Sometimes we are hesitant to communicate prognosis because we are worried about the negative psychological effects that it might have on the patient's family. This can then in turn lead to poor exchange of information. One of the biggest worries is that it could potentially be used to exclude parents from making decisions of whether or not to continue treatment. If a provider is uncertain about prognosis and therefore worried that they might let a baby die that would have had a good outcome, they might err on the side of not having such discussions at all, leading to withdrawal of life-sustaining therapies not even being a possibility in the first place. Neurological impairments are hard to predict in the newborn period. As previously mentioned, epidemiologic data provide some insight into the likelihood of a given outcome, but the individual's risk is actually unknown. Some infants who are extremely sick at birth go on to have better than predicted outcomes. Others who have seemed to have done well in the NICU only manifest sequelae over time. MRI and other tests are used to help predict outcomes, but are most helpful in extreme situations and fail to inform those that are more ambiguous. It is important to note that most infant deaths after birth asphyxia occur after redirection of care, potentially biasing our understanding of outcome statistics in important ways. The self-fulfilling prophecy described by Mercurio and Wilkinson is something that we must be aware of when we interpret an outcome statistics in preparation for consultation with families. In the self-fulfilling prophecy, populations such as patients with severe HIE are known to have a high mortality rate in the literature. Once a baby is born and diagnosed with severe HIE, we then predict that they might have a high chance of passing away. Treatment limitation discussions are then held, which may lead to withdrawal of life-sustaining treatment for these patients. Then the patient dies, only to reinforce our intuition that this patient population has a high mortality rate. While biased perception of HIE-related mortality has the potential to deprive infants who might have survived with that opportunity, hypervigilance to this phenomenon might lead some clinicians to overlook signs of a poor prognosis. However, if prognosis is accurate and treatment is withdrawn, then the way that the patient died will change, but not the outcome. This is how we hope we are providing best practice for our patients. Uncertainty is not always a bad thing. Before targeted treatment, we were able to provide a grim prognosis with more certainty in the sickest babies. However, now with the advent of cooling, there is a better chance of survival without major disability. Learning to embrace uncertainty and how to manage it is probably the best way to deal with it because it will likely never go away. I think Dominic Wilkinson describes uncertainty well in this quote. The important question is not whether there is uncertainty, but whether there is sufficient uncertainty that treatment must continue. There is a point where we know that the outcomes are often poor enough that we should be discussing with the family whether or not continuation of life-sustaining treatment is in the best interest of the baby. Before that point, it is in the baby's best interest to continue all intensive therapies, at least until we gather more information. A more uncomfortable topic within the realm of ethical issues regarding this patient population is the window of opportunity. Sequelae of HIE often take months or even years to become apparent. Even in the presence of severe brain injury, newborn infants may appear relatively healthy. Therefore, until functional testing can be done, physicians rely heavily on epidemiologic data, labs, and imaging to help parents anticipate the outcome. Considerable weight is thus placed on MRI obtained after therapeutic hypothermia has been completed and often after the infant has been stabilized. Though helpful, MRI is not definitive in regard to prognostication. In our case presentation, by the time the extent of Sarah's brain injury was clear and her parents were able to engage with the team for more meaningful values-based decision-making, there was nothing to decide. As her parents considered whether they felt that Sarah now faced a fate worse than death, Sarah was stable, breathing on her own, and eating as any other baby would. Although great care should never be taken to refer to an infant's death as an opportunity, this case highlights the conceptual usefulness of the term window of opportunity, also described by Dominic Wilkinson, as the period of time when a patient is entirely dependent on medical interventions to survive. It is during this period that discussion of redirection of care decisions to allow for more accurate prognostication. Such prognostication is often of limited utility. The infant survives, but with severe neurological impairments, regardless of the parents' values about this health state. HIE is unique in the sense that there is often a short time period of critical intensive care where we worry about the baby's survival and prognosis. Some might argue that because the burden of being on a mechanical ventilator is a very short time and minimal, it would not be in the patient's best interest to withdraw intensive treatment. And if the patient truly required withdrawal, they would have a continued need for the mechanical ventilator. Additionally, some may argue that there is a conflict with the doctrine of double effect. If the timing of treatment withdrawal is influenced by whether or not the infant will die, it might appear that the death was intended, or that extubation leads to a direct goal of death. Lastly, there are arguments that there should never be a window of opportunity. If we were certain that the baby would die, then we know that the baby would die. However, for those that believe that there is a fate worse than death, this is a troublesome outcome. Ultimately, quality of life judgments are at play. There are important considerations when thinking about timing of withdrawal of life-sustaining therapies in newborns with HIE, described well within this table. The earlier that we consider withdrawal of life-sustaining therapies, the less certain we are regarding the prognosis of the baby. We often do not have MRI, and we do not also have multiple days of data with EEG or repeated neurological examinations. Waiting for this information might give more confidence to the prognosis, but it comes with the risk of passing time where a baby might not be ventilator dependent any longer. When thinking about early treatment withdrawal, it would make sense that a baby who is ventilator dependent has a higher chance of passing away on the mechanical ventilator compared to a baby who is on less respiratory support. In this case, there is a higher chance of death compared to survival with severe disability. For families who believe that there is a fate worse than death, this might be a consideration for early withdrawal. Rushing a family to make this decision would be horrible, though sometimes there is nothing to do but to wait for them to process and to see what happens with the patient. Later withdrawal of life-sustaining treatment for infants with a poorer prognosis could include withdrawal of artificial or enteral nutrition in some cases. Many severely asphyxiated infants are not able to bottle feed due to the inconsistent suck, swallow, breathe reflex, as well as lack of a gag reflex. In those cases, they are usually started on enteral feeds through a gavage tube. Although the American Academy of Pediatrics provides guidance that withdrawal of nutrition is not fundamentally different than withholding other medical interventions such as a ventilator, the notion of withdrawal of nutrition is often troubling for many providers and families. It may in part be due to the fact that all babies rely on being fed compared to older children or adults who would otherwise eat on their own if they had the neurological capability to do so. Additionally, providers and families may not feel comfortable with proceeding with withdrawal of nutrition, as it takes several days to weeks for a baby to pass away compared to the minutes to hours that frequently happens following compassionate extubation from the mechanical ventilator. So far, we've discussed several aspects of contemporary care of infants with severe HIE and the associated ethical challenges, particularly in regard to respecting parents as natural surrogate decision makers for their children and values-based decision making. First, birth asphyxia and HIE are rarely anticipated prior to delivery, eliminating the opportunity for prenatal counseling and decision making. Second, asphyxiated infants are often extremely ill, and minute-to-minute critical care decisions dominate the early hospitalization. Third, difficult conversations involving complex information and bad news must occur before the physician and other providers have forged relationships with the parents and other family members. Fourth, decisions are extremely high stakes. Both providers and parents might be reluctant to commit to irrevocably discontinuing medical intervention without allowing time for the medical realities to declare themselves. And finally, experienced clinicians might recognize and become resigned to the seemingly inevitable outcomes of death or severe neurological impairment and feel moral distress as critical care continues. Let's talk more in detail about decision-making for patients with HIE. I think that a brief historical overview will help put this into context. Years ago, a paternalistic approach existed, with decisions recommended or made by the physician despite parental authority. Nonetheless, parents were able to make treatment decisions with the medical team that treatment might be withheld in certain scenarios where a patient would be viewed as high risk for disability. Since then, there has been a change in the societal view on patients with disability. From a legal perspective, a profound and historic shift in disability public policy occurred in 1973 with the passage of Section 504 of the 1973 Rehabilitation Act, leading to federal protection of such infants. Section 504 banned discrimination on the basis of disability. The resulting life at all costs perspective sparked criticism. At the time, there were cases where the Supreme Court ruled against parents and physicians to provide all life-sustaining therapies if there was a medical need. Some argued that there was no obligation to provide these therapies if a neonate was dying or had no potential for relationships. Later, the Child Abuse Amendments of 1984 came about to prevent withholding of necessary medical treatments for disabled infants. The law stated that caregivers were required to provide medication, nutrition, and hydration unless a child is chronically or irreversibly comatose, or the treatment were prolonged dying and not effectively correct all of the infant's life-threatening conditions, or was deemed futile. Fast forward to 1985, a formal American Academy of Pediatrics Committee on Bioethics was formed. However, it was not until 1994 that there was a written guideline published from the AAP regarding foregoing life-sustaining medical therapies for children using the best interest standard and collaborative decision-making with parents. The American Academy of Pediatrics has provided guidelines with the most recent update in 2017 on foregoing life-sustaining treatment in certain cases, including babies who survived profound asphyxia, where the prognosis was uncertain but likely to be very poor, and survival may be accompanied by high risk of permanent, severe neurodevelopmental and other special healthcare needs. In these circumstances, it is ethically supportable for decisions about foregoing life-sustaining medical therapies developed in a context of shared decision-making with professionals involved to be determined by parental preferences. This figure is a simple but effective representation of the role of parental authority across the spectrum of potential outcomes. But in the case that I presented earlier regarding baby Sarah, it was difficult to apply. On one hand, Sarah's initial illness was so severe that one might have been able to argue that the burdens of treatment outweighed the potential benefits, and that the team had an ethical obligation to remove life-sustaining therapies and to allow her to die, avoiding both death after invasive treatment and survival with severe neurological impairment, but potentially reinforcing the self-fulfilling prophecy. Others might have argued that in the age of effective targeted treatment for HIE, and in the absence of prognostic information such as MRI, the only permissible course of action was continued intensive care, with recognition that the so-called window of opportunity might be lost. Throughout her hospital course, however, Sarah's doctors placed her into a more ambiguous category, in which her outcome was viewed as highly uncertain, and her parents should drive decision-making. Considerable work has been done in the field of values-based decision-making, but this work has largely focused around marginal gestational viability and following prenatal diagnosis of well-understood congenital anomalies in genetic conditions. Models exist for how to provide expected parents with outcome information. In these situations, parents often have time to adjust their expectations in anticipating bringing home a baby with complex medical needs. In some of these cases, parents have a choice regarding whether and how resuscitation is initiated. How to best provide anticipatory guidance and engage parents as active participants in resuscitation decisions has been extensively studied. However, these models are not applicable to resuscitation and early intensive care decisions for asphyxiated infants with HIE. In these situations, care decisions, the first discussions with parents, likely occur after the infant has been resuscitated, at a time where parents have had minimal opportunity to adjust their expectations. Unless stillbirth is confirmed before delivery, parents are not offered the opportunity to forego aggressive resuscitation after birth. Although how to best share bad news and engage in difficult conversations is an increasingly large focus of medical training, communication specifically around asphyxiated infants is not well studied. In cases of patients with severe HIE, providing intensive care ensures that we are saving all potentially neurologically intact infants, but this can lead to cases of outcomes where it may not be in line with parents' values. On the other hand, withdrawal of intensive care might lead to the potential death of a patient that would have had a good outcome. Either way, it may not be possible to avoid what for some may be the ultimately least desirable outcome. The issue at hand comes down to quality of life judgments. Many people would say that a good outcome would be living with unimpaired survival. Historically, we have viewed poor neurological outcome as an unequivocally bad outcome, as we would death after a trial therapy in the NICU. More recent studies suggest that some parents may place a more positive outlook on survival with impairment and worry more about missed opportunities for survival. To what degree of neurological impairment is acceptable for one family may be different than what is acceptable for another family. Some may say that survival with severe impairment would be a fate worse than death. Others may say that any survival, no matter what the neurological outcome, is better than dying. With this in mind, eliciting parental values in situations of uncertainty is essential in providing quality care and consultation. I've left you with a major problem but no solution. Unfortunately, there is no solution, but there are some considerations we should have while caring for this subset of patients. We need to be open and honest about prognostic uncertainty that we are facing. We need to consider ways to improve accuracy of imaging and other ways to obtain earlier imaging that might be helpful for better prognostic certainty. Meanwhile, we should not delay eliciting parental values. To do this better, we need to continue to work on our shared decision-making skills. When a decision has not been made, or we are not sure what the parents would want, our best option may be to err on the side of aggressive treatment. Lastly, we need to have humility and educate ourselves on how to do all of this better. Now let's move on to some other current ethical issues in this patient population. Expansion outside of clinical trials for therapeutic hypothermia should provoke serious thought. We want to be innovative and expand this therapy to include as many babies as possible in hopes to provide a better outcome for more infants. However, without the research to show safety and efficacy, we do not know if this is the right thing to do. What if it led to higher morbidity and mortality in some patient populations? There is significant prognostic uncertainty that could lead to imparting an unknowable risk for such patients. With such uncertainty, we need to balance access to therapy with protection of the patients in regard to the uncertainty. Currently, protocols state that with this therapy, it should be offered in patients over 35 to 36 weeks gestation and patients that are over 1,800 grams. But what if a patient was diagnosed with HIE at 34 weeks and 5 days? This is a current issue that plagues many neonatologist minds when the issue arises. Standard delivery room care focuses on keeping newborns warm, especially those who are premature, because there is evidence that premature babies are at higher risk of morbidity and mortality when they are cold. Retrospective reviews are conflicting on their evidence in providing therapeutic hypothermia for late preterm infants, but a randomized controlled trial is underway, which will hopefully provide us with outcomes to propose more clear guidelines for this patient population. In the meantime, it is important to weigh the risks versus benefits and to have a thorough discussion with the parents before administering a treatment where the risk-benefit ratio is yet to be determined. What about patients with chromosomal abnormalities or syndromes? Studies using therapeutic hypothermia included this patient population, and it makes sense when you think about it how this could be a confounding factor when trying to study the outcome of cooling therapy, as patients in this situation are often at high risk for neurodevelopmental disability independent of hypoxic ischemic encephalopathy. Additionally, it would be difficult to distinguish encephalopathy due to HIE from encephalopathy due to brain-related injury in the setting of a congenital anomaly. But this means that we don't know how well it works in a complicated patient population. There have been retrospective reviews completed, though only with a small subset of patients. Studies have shown that there is a higher association of patients with underlying congenital anomalies having hypoxic ischemic encephalopathy. In the case of prenatally known genetic syndromes, unless the parents have already decided to forego critical care therapies, it is probably best to provide the therapy regardless of the neurological prognosis associated with the genetic syndrome. Withholding therapeutic hypothermia should not be done unless data supports that decision. Cases of mild encephalopathy are also complex. At this point in time, we do not offer therapeutic hypothermia for patients with mild encephalopathy, though studies are underway. Eligibility takes into account both the perinatal events as well as the infant's condition after birth. If the baby doesn't quite fit into the criteria and the targeted treatment is not provided, there is a fear that we may miss offering it to some babies that might have benefited from it. Historically, the thought was that there may not be enough benefit to gain from cooling patients with mild HIE, but given the low risks associated with it, this has been brought into question. One current issue for caring for neonates with HIE is rather in the delivery room, when to stop resuscitation. In the year 2000, the Neonatal Resuscitation Program guidelines suggested that discontinuation of resuscitative efforts at 15 minutes might be warranted if spontaneous circulation has not been established. In 2005, the guidelines were revised to advise that discontinuation might be warranted after 10 minutes of adequate resuscitation. More recently, in 2010 and 2015, the International Liaison Committee for Resuscitation is unchanged in this recommendation, suggesting that in babies with an APGAR score of 0 after 10 minutes of resuscitation, it may be reasonable to stop resuscitation. However, the decision to continue versus discontinue resuscitative efforts should be individualized. For those who have been in this situation, we know that 10 minutes goes by very fast. It is unlikely for even a skilled resuscitation team to feel as though they have completed all of the optimal steps to convince themselves that they won't be able to stabilize the baby. Prior to the use of therapeutic hypothermia, previous studies showed poor outcomes for patients with APGAR scores of 0 at 10 minutes of life. A closer, more recent look at the data showed that outcomes are not actually universally poor. Some studies show that over 20% of babies with an APGAR score of 0 at 10 minutes will survive without major disability. Interestingly, a retrospective review in Japan showed a much higher rate of survival in this patient population, but that the overwhelming majority of survivors were severely disabled at follow-up. They commented on the societal reluctance to withdraw life support in their country. If the philosophy of a unit is not to withdraw life-sustaining therapies, there will be more survivors. Vice versa, if there is a unit that is more likely to have treatment limitation discussions and withdrawal of life-sustaining therapies, they may have a lower disability rate, but they will likely have a lower survival rate as well. Finally, I would like to comment about some ethical considerations of patients with HIE in developing countries. HIE is a major problem in developing nations, as I commented earlier in the presentation, that studies show it can occur in up to a quarter of all births. Literature shows that approximately 15% of affected neonates will die in the NICU, 10 to 15% will develop cerebral palsy, and up to 40% will have other disabilities. There are a number of population differences that might address why it is more common, including a lack of prenatal care and a higher risk of maternal health issues. More babies will have malnutrition, growth restriction, and may have pre-existing brain injury. Most deliveries occur outside of hospitals, and there is a lack of access to intensive care. This would be concerning with the issue of timing of onset of cooling, which should occur within the first 6 hours of birth. Moreover, sepsis is common and might be hard to differentiate from HIE at birth. For these reasons, it would be challenging to extrapolate the effectiveness of cooling in this patient population. There are a number of reasons why hypothermia trials may not be applied to use in low-resource settings. First, neonates that require a high level of supportive care are not as likely to survive in low-resource settings. Survival with disability may lead to high economic burden on families. Provision of intensive resources as a bridge to a survival with severe impairment must be approached with caution if we are not able to provide long-term care for such patients. In settings where basic normothermia isn't uniform, studying the impact of deliberate hypothermia is confounded. Furthermore, the equipment for therapeutic hypothermia is high-tech and expensive, and therefore would be difficult for hospitals to acquire and maintain. Lastly, it would be unethical to provide such equipment if there were a lack of skilled staff and tools needed for basic monitoring for patients to undergo the treatment safely. How to perform cooling trials in resource-limited settings is debatable. As we all know, ethical problems arise when trying to study high-technology interventions in low-resource settings. Randomizing infants to normothermia versus hypothermia would mean that we know we are putting normothermic infants at risk compared to treatment in the United States. Some people propose that participants be offered the minimum of best intervention currently available as part of a national public health system. Regardless, trials are needed to assess safety in this setting. One thing we could consider is performing research on lower tech ways to perform cooling for such patients. Lastly, it might be more impactful and efficacious to focus our resources and funding to address the underlying cause rather than providing possible treatments that might be only successful in very specific settings in low resource center countries. In summary, with advanced medical therapies, complex neuroimaging, and delayed manifestation of sequelae in patients with HIE, I argue that there is continued need for ethical analysis of how we care for these patients. I would like to conclude by summarizing my key points. Hypoxic ischemic encephalopathy is a life-threatening illness in newborns, leading to multi-organ dysfunction and brain injury. A time window exists where patients are critically ill and withdrawal of life-sustaining therapies might be appropriate in some cases. Prognostic uncertainty cannot be resolved and must be acknowledged with families early in the treatment course. A shared decision-making approach may help to elicit parental values placed on different outcomes. Bias and self-fulfilling prophecy warrant mindfulness and humility in practice. Despite current recommendations on considering discontinuing resuscitation for neonates with APGAR scores of 0 at 10 minutes of life, this remains practically and ethically challenging. And lastly, further research is needed to define the role of therapeutic hypothermia in previously excluded patient groups and in resource-limited settings. Thank you so much for the opportunity to speak with you today and for your attention. I would like to take this time to answer any questions.